The patient presenting with polycythemia vera, and as we approach the diagnosis, clearly we start with really what was our reason for suspicion for them having polycythemia vera to begin with. Did they have a thrombotic event? Did they have an unexpected increase in the counts, unexpected splenomegaly, or unexpected symptoms ranging from headache or fatigue to difficult pruritus? Our diagnosis really begins with our preclinical suspicion because it heavily informs our workup. One, we clearly begin with the blood counts, and the unexplained erythrocytosis is clearly a key cornerstone. By our 2016 WHO criteria, that's clearly the starting place. The red count is up, it's unexplained. Clearly, if there's leukocytosis and thrombocytosis at the same time, I'm even that much more suspicious. Second, we look at the presence of the JAK2 V617F mutation or the JAK2 exon 12. They typically are tied together these days with reflex testing. The presence of that mutation and unexplained erythrocytosis really takes you most of the way there to a diagnosis. A bone marrow aspirin and biopsy is included in the 2016 criteria, as well as, if the JAK2 mutation is not present, a subnormal erythropoietin level. Now in there, as we identify their risk, we diagnose the patient. We then assess risk on the basis of age, the basis of prior thrombotic events, those clearly increase risk. Higher leukocyte count clearly increases the rate of thrombotic event and likely increases the rate of progression. Now, as we think about goals of therapy, they include trying to, 1, control the hematocrit, 2, by European Leukemia Net criteria, control leukocytosis and thrombocytosis if present, control splenomegaly if it's present, and control symptoms if they are present: fatigue, headaches, spleen-related symptoms, pruritus. So the way I frame it for patients, what is the burden of their disease specifically in terms of risk and disease burden, and then we develop our goals of therapy accordingly.